Hello everyone, my name is Alex Fenn and I am a current fourth-year medical student at Duke University School of Medicine. My presentation is entitled Development and Validation of Machine Learning Models to Predict Admission from the Emergency Department to Inpatient and Intensive Care Units, which I worked on in conjunction with Duke Emergency Medicine and the Duke Institute for Health Innovation. To begin, we know that the number of ED visits in the United States is increasing. This ever-increasing number of ED visits has resulted in a subsequent increased demand on EDs, which are straining to keep up, and over 90% of EDs routinely report crowded conditions. Though delayed patient flow throughout the hospital and subsequent ED overcrowding is multifactorial, a frequently cited reason for overcrowding is the wait for an inpatient hospital bed. Boarding begins when the clinical decision has been made to admit the patient to an inpatient unit and is often prolonged because demand for inpatient beds is greater than the supply. Prior studies have demonstrated that machine learning can be utilized to understand the causes of ED overcrowding and to more efficiently triage patients, and prior models have been developed that attempt to predict hospital admission to either an inpatient or ICU at the time of ED triage. However, a recent systematic review demonstrated that many of these machine learning studies do not include details regarding implementation of models in a clinical setting. This study set out to develop and validate two machine learning models. Upon arrival to the ED, one model would predict probability of patient admission to an inpatient unit, and another model, upon patient arrival to the ED, would predict probability of patient admission to an ICU. These models would run every hour from a patient's initial presentation to the ED, that is triage, throughout a patient's stay in the ED until a disposition decision is made. Another goal of this study was to provide framework for clinically implementing the model, with the goal of eventually using these models to help improve patient flow throughout the hospital system. This study utilized data from Duke University Health System, which is a 3-site hospital system that has 1 academic and 2 community-based emergency departments. We created an initial cohort of adult patients who presented to these EDs from October 2015 to August 2018, giving us just over 468,000 encounters. We then created a validation cohort of all patients who presented to these EDs from January to December of 2019, over 153,000 encounters. This cohort was created in order to validate the model on a time period outside of the initial training period. We looked to previous studies to determine which EHR data elements to include as model features. These elements include, but are not limited to, items such as age, patient comorbidities and history, triage elements, orders, labs, and medications at triage. In order to assess model performance, we use 2 metrics that are common in the world of machine learning, the AUROC and the AUPRC. The AUROC demonstrates the trade-off between the true positive rate and false positive rate across different thresholds. And the AUPRC demonstrates the trade-off between precision, the positive predictive value, and recall, true positive rate, across different thresholds. These metrics were calculated both in aggregate as well as during each hour of encountered data. Here are the model results for the retrospective cohort in both graph and table form. The blue line graphs the overall performance across all 3 hospitals. Overall, when looking at both the AUROC and AUPRC, our admission and ICU models achieve similar results as the most accurate machine learning models that have previously been published. Importantly, we found that the model performs similarly across different hospital settings. The orange line, Hospital A, represents an academic-centered ED, and the green and red lines represent hospitals B and C, which are community-based hospital EDs. This slide shows the model results for the 2019 cohort. Again, the model performs similarly across academic and community-based hospital settings. This table shows the comparison in performance between the retrospective cohort and the 2019 validation cohort. Overall, the admission prediction performance between the two cohorts is very similar, though the ICU performance did decrease slightly in the 2019 cohort. We believe these are important results as they validate and demonstrate model efficacy for a time period that is beyond the initial training period. These graphs show the AUROC, solid lines, and the AUPRC, the dotted lines, model performance for the retrospective cohort for each hour. Again, the models tend to perform similarly across the different hospital settings. Importantly, whereas other studies focused primarily upon admission prediction at the time of triage, that is, hour 0, our model makes predictions up to 24 hours after the initial arrival in triage, incorporating additional data elements at each hour. In general, there is a peak in model performance for both metrics around hours 2 through 4. On this slide, we have the 2019 results by hour, redemonstrating similar performance at different hospital settings. These hourly results do look slightly different than the 2015 to 2018 results. The most accurate hours for this cohort tend to be slightly earlier than the retrospective cohort, with the initial prediction hour 0 and hour 1 having the highest AUROC values. For the admission model, unique to this cohort, AUPRC values increase throughout the encounter and are generally most accurate at the last hour of encounter. Here are the comparative results by hour for both cohorts. The left-hand column shows the performance at the time of triage, hour 0, which is very similar across the two different cohorts. The right-hand column shows the hour and value for when the model reached its maximum performance, which does vary slightly in our retrospective and 2019 cohorts. One explanation for this difference, and also a potential explanation for the drop in aggregate overall performance in the 2019 ICU model, is that there was a difference in the admission and ICU prevalence between the two cohorts, which resulted in models that performed differently and an ICU model that was slightly less accurate on 2019 data. Given the promising results of the retrospective and validation data, the next aim of this study was to provide a framework for which this model could be implemented into a clinical setting. The model was transferred from running retrospectively to running on real-time patient data as patients present to the emergency department. A clinical user dashboard was developed which displays information regarding bed view of patients and likelihood of admission for each individual patient. This is demonstrated in this image. As of right now, this model is not being used to make any operational decisions, but is operating in silent mode as we collect data on prediction accuracy for this new cohort of real-time patients. Here are the most recent model performance statistics for the real-time cohort. This represents 50 days and over 14,000 encounters. We are happy to report that, so far, the performance on this real-time 2020 data is similar to the performance that we saw in our retrospective and validation cohorts. In conclusion, the results of this study demonstrate that machine learning models can be developed to accurately make predictions regarding the probability of inpatient or ICU admission throughout the first 24 hours of a patient's encounter in the ED, not just at the time of triage. These models are accurate in both academic and community-based settings and on a patient cohort beyond the time period of the initial training data. These models have also been integrated to run on live EHR data with similar performance. The ongoing silent mode validation period allows for additional information to be gathered before these models are used in any clinical or operational decision making. Further iterations of the models are planned in order to refine and increase model performance. Additionally, in order to more fully determine the effect of prediction models in clinical and operational workflows, such as increasing patient flow through the ED, additional studies will be necessary. Thank you to everyone for listening to my presentation. Thank you to all of my co-authors, Duke EM, DHI, and the Duke University School of Medicine.